post it on La Lima.
Okay.
So it's on the La Lima tab.
No, I just want to hear the voice too.
Okay, you're recording also.
That's why I'm recording, so I can
Yeah, no problem.
send the link for everyone.
Is that why this is next to me already?
We all have.
We all have, yeah.
Yeah, so wipe it down with the like. I'll give you the small one. There's more back there too.
Oh.
If you want.
Kirkland makes lights now.
Yeah, me too.
Great.
So what do you guys want to do first?
Where are you on?
I did squats
Three.
the other day. Why did you
Right over there.
You want to do quads?
I did squats, so yeah, my quads are all. But whatever. Sure.
Just one big piece. That's one big piece.
So if I was to purchase a foam roller, the long ones are really the better ones to get because you can do so much more with them. But for the quads and hamstrings and calf and everything, you can do it with the long ones, but sometimes it's easier with the short ones. So if you guys get down and the floor was just soft. The floor was soft. Sometimes it looks like big. Either one of these or what is the yoga mat? But if you do a plank on here, then you can foam roll your quads. So go ahead and throw the foam roller down on the ground. Rather than you do a plank right on here. So you go on your elbows. And then you can get both quads at the same time, which is nice to do because then the pressure, your body weight is distributed evenly over both, so it's less sore. And then you have the long one like this. You gotta scoot all the way to the side of the foam roller, so like that if you only want to do one leg. And it's gonna be a lot more pressure.
Oh yeah.
And so that's easier if you only want to do one with the half foam roll, so you don't have to move it all the way down to the side. And then if you find one spot that's super tight, you could stop on that spot, and then you could bend your knee and straighten it. So go ahead and flex your knee, and then straighten it. And then you get active release technique, self-active release technique. So you just straighten, bend for like 5 reps. And then you loosen up the quads. So you guys could go, everybody go practice that. And then he could do the same thing, he could do both legs at the same time. And then he can hold himself up with his arms, and you can roll out both hamstrings at the same time. You go up and down. Yeah, or you could scoot all the way to the side and scoot one hamstring. And so if you wanted to foam roll his semimembranosus and semitendinosus, what would you do? So you could internally rotate his femur. And so you'll get the medial hamstring muscles. And then if you want to get his biceps femoris, you can externally rotate his femur. With the lateral hamstring muscles. You guys can go practice that one. Fall back like this and touch the ground. Just take a deep breath and let your arms relax. And so then you should get a nice stretch right in the pecs. Some patients you might have to play around with it, make their arms a little bit higher, get a bigger stretch, a little bit lower, they might not feel it. And then from there, so squeeze yourself really tight, hold it for 10 seconds. And then let yourself fall back into that stretch. And so that's a self PNF contract relax. You're not, making the muscle contract at the end range, but it's still a nice way to get them a little bit extra flexibility. It still works. And then one more stretch that you can do is you can do a scissors motion. So if he has his hands here, you can drop one hand up, another hand down, and try and let your arm just fall all the way to the ground. And then that hand there, yeah. And so you get a nice big stretch for your shoulder, the shoulder flexion, and then you can switch into the other side. Shoulder flexion stretch here. So you guys can practice those. If you're on the small one, what you guys assess is either it might be a C7 radiculopathy, a C6 radiculopathy, something like that is going to be on the exam. You're going to assess the myotone or the deep tendon reflex. And then you're going to walk them through the exercise, and you're going to ask them where their pain is. And so they might say, oh, my pain's in my elbow, my pain's in the back of my shoulder, my pain's in the shoulder blade. And you're going to, let's do some chin tucks. And then you're going to determine whether, okay, that's all you need, or I need the progressive forces. And then you're going to progress the forces. You're going to recheck the hard neural sign. If it's better, it's working. If it's worse, it's not working. If it's the same, you might need the progressive forces. So you're going to have to remember your myotones and deep tendon reflexes. And you're going to have to test at the beginning, test at the end. And so for how the red light, yellow light, and green light works. Say I'm treating a patient, pain in the shoulder blade. 5 out of 10, burning pain in the shoulder blade. We do 10 chin tucks, and I ask them, how's your pain now? They say, 5 out of 10, burning pain in the shoulder blade. So it did not change. So what do you do if it doesn't change? Not better, not worse, it's the same. So what's the next step? We progress the forces. So that's a yellow light. It did not change. And so what are you doing when you're driving down the street and you see a yellow light? You speed up a little bit and you keep going, right? You get through that yellow light, right? So you progress the forces. You hit the gas pedal a little bit and go a little bit further. And so the next thing that you're going to do is let's do a chin tuck with overpressure. And so then you do the chin tuck with overpressure. You assess the person's pain. You go, oh, it's not in my shoulder blade anymore, but now my neck is a little bit sore. Now it's centralized. It got better, came towards the center. So now what do you do? Green light, that's where you go. That's the exercise for that patient. You're not going to progress them any further because that exercise is working. So if you're going towards a green light, you don't need to speed up and hit the gas pedal to get that green light. Just keep going with that. Well, you shouldn't speed up to go through a green light, right?
You don't need to cut me off. I'm going to cut you.
If I gave them the chin tucks with overpressure and I say, how's your pain now? And you go, oh, it's not in my shoulder blade anymore, my pinky finger's not down.
Step.
Peripheralized. That's a red light.
Wow.
We're going to
Go
stop.
Stop.
And I'm going to change forces. And so you can go lateral. You're going to either go rotation towards or side bending towards. And then see how it goes. Does that make sense how you do the red light, yellow light, green light? Okay, so the progression of forces is, does somebody have a clean table?
I think.
Bobby, where's your table? Over there.
Oh, I'm sitting next to it here.
Or down. Okay, so the first one that you're going to do is supine chin tuck. So Bobby, you can lie on your back. And then everybody stands 6 feet away. And I'm going to ask Bobby to take his mask off if you're cool with that, just so he can see his chin. Or at least like lift it up like that. That's good. And so from there, we could ask him to do a chin tuck down into the table. Perfect. Let's do 10 repetitions of that. Try to go even further. Try to tuck your chin even more. Perfect. So you could do 10 chin tucks in that position. I'm going to raise up a little bit. It's a little bit too much extension. Keep going. Try again. Good. And then after he does a set of 10, I'm going to reassess his symptoms. And I could do 2 or 3 sets of 10 before I decide to go on. If it's no change, and then I could try 2 or 3 sets of this. If there's no change with each of those sets, then the progression is I'm going to have him sit up. And then from there, You want to make sure the patient's sitting with good posture. You don't want him to slouch. And then you're going to ask him to perform a chin tuck in sitting. So does anybody have any good verbal cues that you use for your patients to get them to perform a chin tuck? This is a hard thing for, you guys can all do it fine because you have an understanding of how the body works, but a patient who's never done this before will find it challenging to do. And so,
It's like
Do a double chin.
make a double chin.
Double
Well,
chin.
But the key is you want them to look straight ahead. You don't want them to look up, you don't want them to look down. So you can say, imagine your head is on the drawer, and you're gonna push that drawer straight back. And then go as far back as you can. And then come out of it. And when you come out of it, you don't want them to, a lot of times they'll try to do this and look really forward. Just relax back to neutral, and then come in. And another one that works really good is the pie. If they don't get that, you can say, I'm hitting you in the face with a pie. So there's a pie coming at your face, what do you do? Make a chin tuck. And so from there, 3 sets of 10. Assess after each set. If it's a yellow light, we're going to progress him, and he's going to do overpressure at the end. So we do a chin tuck, and at the end, go ahead and apply a little overpressure straight back. 3 sets of 10 like that. If it's a yellow light, we're going to do a chin tuck, and then you can look straight up towards the ceiling. And then look at So get there, try to relax in that position, don't say it 2 times. Lay neck, relax, and try to look all the way up to the ceiling, as high as you can. And the first time the patient does it, they're going to be like Bobby, and they're going to have a hard time looking up. But you really want the patient to, go ahead, Bobby, go with the chin tuck. You really want to get them all the way, all the way, all the way, all the way up, as far as possible. Because the real improvement in symptoms, like the position that Shauna's in, is when they get to end range. But they might not. The first day they do it, they might only be able to do a Bobby swing. And that's fine. We do 3 sets of 10 like that. But maybe after 2 or 3 sessions, they might be able to go all the way up. And when they go all the way up, that's when the symptoms really start to centralize. And so then once they can get all the way up, the final progression is the wiggle at the end. Like with Bobby, we wouldn't ask him to wiggle because he's not getting all the way up there. But Shauna could do a nice wiggle at the end if you look at Shauna. So little wiggle right at the end. And then if any of those causes symptoms to peripheralize, we're going to go lateral. So you can start with side bending towards, 10 times like that, just back to the center, side bending towards, or then you can add overpressure to side bending. And so if you would have a radiculopathy on this side, you would add overpressure to it. And then if that didn't work, we could try rotation towards. So you just look towards, and then away. Look towards, and then away. And so then if we want to progress the forces on there, he could just take his hand on his chin, and add a little overpressure.
Towards the symptom.
Huh? So we're going towards the same side. You're always looking towards the same side. And then if that doesn't work, you could go opposite. But really, if you guys ever have the chance to take a Mackenzie course, you should take it. It comes to Hawaii probably every year. And you could go through a whole weekend where they talk about the Mackenzie philosophy. And how they teach Mackenzie is that you can use Mackenzie on every single patient. So you can use these progressions of forces on everybody. And just depending on how they respond, you can adjust the forces and you can treat any kind of patient. In reality, so I started with that. That's what I learned when I first got to school. I did it, and it worked great for a lot of patients, but there was some patients that it didn't work for. And then once I did my orthopedic residency, I learned a whole bunch of other ways to treat. I learned other manual techniques. I learned more about pathologies. You realize that Mackenzie is great, but it's great for a cervical radiculopathy that is caused by a herniated disc. Because we want to put pressure on that disc to push the disc away from the nerve. And that's what Mackenzie progression of force really does. But in reality, you're going to get a diagnosis of neck pain, or you're going to get a diagnosis of cervical radiculopathy. In cervical radiculopathy, this means that a nerve root is irritated. It doesn't tell you why. So the nerve root can be irritated from stenosis, the nerve root can be irritated just from inflammation, the nerve root can be irritated by bone spurs, or it can be a herniated disc that's irritated the nerve root. So when it is the instance of a herniated disc, the patients will respond really well. And so I'll try it, but I might not know. If there's no MRI, I mean, I could do my assessment and I find hard neurologic signs and I have a good idea. This is a younger person, I have a good idea it's a disc, but I don't really know. And it's not my job to tell a patient that that's their diagnosis. That's the doctor's job. And I cannot make that because I'm a physical therapist. But those are the patients who it works with. And so this is like, it's like a hammer, right? You use a hammer to hit nails. You don't use a hammer to hit everything. Like there's different tools that are good for different things. So this is one tool that you guys can have in your toolbox when you use this. But know that it doesn't work for everybody. And there's gonna be a therapist who you're gonna come across in your life who's a McKenzie therapist who does it with everybody. Right? And that's fine if you're, and they're gonna seem really good. They're gonna sell it really good. The patients are, put this around here. And let's pretend, Bobby, that your knee can only bend to here. And it stops right about there. So he should be able to bend his knee all the way. Go a little bit further. He should have that much, but he doesn't. He stops right here. So that's where his knee is limited. Somebody raise the table up a little bit higher for me. And so what we can have him do is I can ask him to perform a heel slide. And then once you get to end range, I want you to pull a little bit further. And then you're going to relax and come out of it. So you're just going to hold it for a couple seconds and relax and come out of it. So go ahead and do that. And when you get to the end, I'm going to apply a little bit more pressure. So I can just come here, and then I can squeeze. And then you can relax and make your knee straight. And then I come up and bend your knee again. Squeeze. And then come back. So every time he's at the end range, I apply that squeeze. And that should mobilize his tibia posteriorly to help get him a little bit extra range of motion. And then also this works really well if somebody has a little bit of knee pain with deep squatting. You could do this mobilization 10 times, ask them to squat again. Sometimes their knee pain will go away. So I've had it work, with a small percentage of patients with knee pain and squatting. Maybe like 20%. So you guys can go ahead and practice that joint mobilization. And so when you apply a mobilization, remember when we did the shoulder, I was real strict about your guys' angles of your arm. And that's because when we apply a mobilization, you want the direction of your force to be parallel to the concave joint surface. Whether you're mobilizing the concave or the convex surface, you want it parallel to the plane of that joint. So if I'm here, right, I'm going to be pushing with the joint mob right there along the tibia. If his knee is bent this way, my line of force might be more here. If he's all the way straight, my line of force is going to be straight down. So it depends on where he's at. You're going to adjust your line of force for this mobilization. So if I come here, I could stabilize with one hand on his tibia, and my other hand is just going to be right here. And I'm going to lean into him, so I take up all the slack in the joint, and then I can apply my mobilization. You guys remember your grades in mobilization? You guys can do grade 1 and grade 2, right?
Mm-hmm.
And so if I do grade 1, it's small amplitude oscillations at the beginning of the range. If I do grade 2, large oscillations at the beginning of the range. If I do grade 3, I can lean into it, right? And I could do large amplitude oscillations at the end of the range. And I could do grade 4, which is small amplitude oscillations at the end of the range. And then another thing that you guys will end up doing is you're going to have a patient with a ACL surgery or some other knee surgery and they're lacking the extension. And it's a priority to get their knee extension back as soon as possible. You're just going to put your hands here and you're just going to do a knee stretch into extension. And you're going to put your body weight and just hold it there. And they're like, that's crazy, that hurts like hell. And you say, it's okay, there's no way to cause any damage, but we need to get you this knee extension back. And then sometimes I'll come here, and I could actually put them here, and I could stabilize, and then I could lean into them this way. And I can get that mobilization. That one feels really nice to the patient.
You had a total knee arthroplasty? Wow, so young.
Look how small the scar is for the total knee replacement. Arthroscopic. The other way I could do it is he lies on his belly. Bend his knee right here. I can apply the joint. And so my line of force is going to change with his tibia. So whatever position his tibia is in, I'm going to change my line of force to go along the tibial plateau. So if I'm right here, 90 degrees, It's going to be a straight mobilization. If I'm here a little bit more, it's going to be more here. If I'm here a little bit more, it's going to be you guys can practice those two mobilizations according to how some of you guys will be. There's a lot of different ways to mobilize a patella. There's going to be one way that you guys like the best, which is the way that you will use the majority of the time. But you have to be able to do it in multiple different ways. And that's because every patient is going to experience your touch differently. And sometimes the patella could be a little bit tender. And so if I like to mobilize the patella superiorly with my fingertips like that, most patients will be like, ah, that's fine. But there might be a patient who'll be like, ah, that's uncomfortable. So you have to change your hand. So you can come this way, and I can do a superior mob with my web space. And I can use my fingertips to do a superior mob. I could use my fingertips this way and grip it, and then use my hand to do a superior mob. And a lot of patients like that, but some patients don't. Or I could just use my hand like this, and I could do a superior mob like that. So there's a lot of different ways to do the superior. If I do an inferior glide, let's come here, glide his patella inferiorly. I can grab it like this, glide it inferiorly. I can just grab it like this, and glide it inferiorly. So you can use this part of your hand, you can use fingertips with that part of your hand, and you can use the web space. There's going to be one way that you like the best, but be able to do multiple different ways. Because there's going to be a patient. Grab this knee and pull it down to your chest. And then relax your leg for me. And then I could take him here, and I could find his ASIS. And I could see that point when his ASIS moves forward. That's going to be the end range. And so the way they did it was they helped stabilize here. Right? And then they can put my hand on his ASIS if I stabilize his ASIS, it'll hold him in a posterior tilt. And so if I bring him down like that, relax for me, take a deep breath. See how his knee goes straight? So I'm stretching him at the hip, but then his knee straightens. And so that when his knee straightens, what he's doing is he's putting slack on the rectus femoris here, so that he can extend his hip more here. So if his knee is straight, he can go further down. But if his knee is bent, he cannot go as far down. So for him, it's more rectus femoris. And so if I was to actually stretch him rather than do the test, I could come here, stabilize one hand here, and then the other hand here, I could push down. And by pushing down on the femur here, I'm really stretching his iliopsoas. So you should feel it more in the front of your hip if I do this. And he's not going to feel it as much in the quads because as I do this, his knee can straighten out to take the pressure off the quads. If I wanted to stretch instead of his iliopsoas, if I wanted to stretch his rectus femoris, I can put my leg here. And so I can apply a bend there and hip extension. So the combination of those two is hip extension, knee flexion. That's a stretch of the rectus femoris. We really get him in there. And then if I wanted to stretch his tensor fasciae lata, I can lock my leg around here and I can push down. And then if I do that, you should feel more of a stretch on the outside. So there's three different ways. There's this right here, there's right here and right here, and then there's right here. So those are the three stretches. And then I can even do a contract relax. Okay, so you feel my hand right here? Push your leg up into my hand, hold that for 10 seconds. 1, 2, 3, 4, 5, 10. You know, deep breath and relax, and then get further down. And you can do a contract relax here, the rectus femoris. You can say you feel my leg right there. Hold it there, don't let me push you back. So we'll hold, relax. And hold that for 10 seconds, and then relax, and then we take it back further. So go ahead and that's a medial glide, right? You can see it gliding medially. Or you can do this, and I have to squat down here, right? Put myself in this position and really move it. I think this, personally, is kind of weak. I mean, so if I'm like working with a patient, it's like poking my patella with my thumbs to the side. And I don't really like this mode. It's fine to do it this way. you are immobilizing legally. But the way I like to do it is if I internally rotate his femur, now I can grab his patella right here. I can lock out my arm and I can
Oh, I
lean
feel
into it.
that moving.
And then you can get a really nice medial patella glide that way. And it's a lot easier on you, and it feels to the patient like you're doing something.
Yeah, compared to the front.
Okay, so she goes into a posterior tilt. It'll get
Oh,
unstuck.
okay.
And she goes into an anterior tilt and pulls it into tension. So you get a much bigger hamstring stretch if the person is in an anterior tilt, or if they have a nice arch in their low back. Because remember, lumbar lordosis goes with an anterior tilt. So the cue you can give them is keep an arch in your low back. So everybody bend down, try and touch your toes right here. And then I have to tell them that you want to bend your elbow. Right? So you want to push straight back like that. And that's a self knee extension stretch. Because that'll help get knee extension back. So not only is she stretching her hamstrings, but she's also mobilizing her own femur posteriorly to help with knee extension. So that's a great stretch, especially if somebody's working a desk job or something, or they just had surgery, they're probably sitting most of the time. You just get them to sit right there, push on their knee. Get that knee extension back. And then the lady was there, and she didn't reach out her hand, so I didn't reach out to shake her hand, but I was telling her she was thinking I was like sexist, like, oh, the guy's hands. But I just felt uncomfortable about shaking hands.
Yeah.
And right after, watch.
No, I this is my culture to kiss people. Sorry.
Or like hugging Tio.
Okay, so you guys are going to take, when we do this, you're going to take your hands like this. And you're going to have them supination, and you're going to grab their hand here. And you really want to get the thumb. Remember, the median nerve gets the muscles of the thumb, so the median nerve is going down here. So if I was just getting here, I wouldn't be getting enough tension on the median nerve. So I'm going here to get nice tension. So that's how you're going to grip it. Okay. And then the first thing you're going to do is take a fist, deep press the shoulder. So you got shoulder depression. And then I'm going to use my knee to bring abduction to 90 degrees. From here, I'm going to externally rotate his shoulder, supinate his forearm, extend the wrist, and extend the foot. It's a manual median nerve. And then right when I start to feel, do you feel tension there? Try to bring your left ear to your left shoulder. Better or worse the same? More or less tension? Bring your right ear to your right shoulder. All the way to my hand. Less tension or more tension? Less. So that's positive, right? So we were able to create tension on this median nerve. So go back to neutral. So if I was to do a tensioner, I would just go to this tension and out of it. So you can actually feel the tension. I'm going right to that tension. No, I'm not going to push through it. Take them into that tension and out. Into the tension, out. If I want to do a glider, I could do it all myself manually. So as I tension it at the elbow, I could slacken it at the wrist. So I come here like this. And he should not feel anything. My tensioner, he should feel it when I get to the end and just out. And then out. Glider, he's not going to feel anything. So I've got a triangle. For median nerve was here, where you're grabbing the thumb, and his forearm is supinated. But for ulnar nerve, his forearm is pronated, and you can grab here the pinky finger. Remember, the ulnar nerve goes to the pinky finger, so I want to make sure I get my hands on the pinky finger to create that tension. Same thing, depress the shoulder blade. Same thing, abduct the shoulder, externally
External
rotate,
rotation.
wrist extension, finger extension, then we do elbow flexion. You feel it already? Where do you feel it? Your pinky? Okay, so now go, bring your ear towards my hand. Should get better. And then bring it away. Okay, so go back to neutral. So if I want to do a tensioner, I could just go here until I feel a tension and then out. Tension, out. Tension, out. If I want to do a glider, I could go here. Nothing. So not that way. So tensioner. So go ahead and practice this. So if we look at the talocrural joint, it's a joint between the tibia and the talus. What joint surface is convex? The tibia or the talus?
Tibia. Tibia. Oh,
Convex.
The talus.
Yeah.
Yeah.
So the top of the talus is
Yeah.
convex. The distal tibia is not. So if I was to mobilize, we look here, dorsiflexion. It's going to be either anterior or posterior. So if I go into dorsiflexion, that's an anterior.
Anterior.
Roll. So I would do a posterior.
Oh,
roll.
posterior.
Okay, so it's an anterior roll, so we need a posterior glide.
Yeah.
Because we have moving convex and convex. So roll and glide goes in the opposite direction. So in order to increase dorsiflexion range of motion, I'm going to mobilize the talus posterior. So there's a few different ways to do mobilization. One is in supine, and another is in prone. So could I have the supine box and then raise your ankle up? So the loss of motion in the ankle that normally happens is a loss of dorsiflexion range of motion. So normally we're going to be doing posterior glides on the talus to increase dorsiflexion. And losing dorsiflexion is a lot more of an issue functionally because we depend on dorsiflexion for so much. Anytime we take a step, we need dorsiflexion. Going down a stair, you need a lot of dorsiflexion. Going uphill, you need dorsiflexion. So if you get stuck here, it really messes you up functionally. Where losing plantar flexion, well, it can mess you up functionally. It doesn't mess you up as much as losing dorsiflexion does. Down here. So if I could come here, I could put Bobby and use my thigh to put Bobby in a slight amount of dorsiflexion. And I could take my web space to my thumb, and I can lean into it, and I can apply a posterior glide. So it'll take this. So that's the way you'd mobilize him to do that. And then I like to do it in prone also. So if he lies on his stomach, and let's do this leg. He bends up to 90 degrees. So those pictures there are from physio tutors. I'm sure you guys have watched some of their videos. And they do it like this. They get the dorsiflexion here, and they pull the ankle forward. But what's a better way to do it is actually to stabilize here on the distal tibia and fibula so that doesn't move. And then I can actually use my armpit to get a little bit of dorsiflexion. I can use my hand. Try relax me. And I can come here. So I can stabilize the tibia and fibula here, and I can mobilize the talus. And I like to do it this way because I can get them there, and I can stretch them into dorsiflexion there, and then I can actually mobilize his subtalar joint a little bit. So when I work on the ankle, I do a lot of it in this position. Just because I can do a lot of different things at once. I can work, massage his calf, do all that stuff in the same position. But you guys can try it both ways.
Okay.
To do the heel down.
So when he's bringing his knee
Forward, I'm
forward,
pushing
you're
back.
pushing.
So this is good for anybody who has no weight-bearing restrictions. Sometimes you might be doing this on an ankle fracture, and they might have weight-bearing restrictions, but you can still mobilize them. But if they don't have any weight-bearing restrictions, this is a great mobilization. So you can just grab the calcaneus, right? You can use my hand here, and I can do a lateral glide, which will increase inversion, and a medial glide, which will increase eversion. Remember, the structure is all crazy in this. That's really good. So just remember that this way is to increase inversion, this way is to increase eversion. But more likely than not, you're going to be doing calcaneal moves just to decrease pain. Normally, the person just has like a pinch in their ankle or a little bit of pain, do a little bit of a mobilization, grade 1, grade 2, and then their pain comes away. But if I can have Bobby lie on his side, then I can take this one here, right, and bring it back here, right, so I could stabilize them in a little bit of dorsiflexion. And then I could just do a glide that way. So I can use my body. And I can bring this one. This is going to be as a medial glide. And then this one here is a lateral glide. So it's a lot easier than sitting down.
And then he can just go on the other side.
Yeah, so if you're doing the same ankle, you just roll them over to the
Okay.
left side. Alright, paper tape. So that we don't wax his leg when he takes it off. And just so we have the right attachment and all that. So let's go back a little bit. And so if you guys remember from palpations, the navicular is right here. So this is the navicular bone right here. And a lot of times patients will have navicular drop, which will result in a collapsed arch or a pronated foot. So we can use a tape-in technique to act as a sling to pull it up to support the arch. And so patients with any sort of pathology that they get pain from the collapsed arch, this is a really quick tape-in technique. It'll take 2 or 3 minutes that could significantly reduce their pain. So I'm going to start with the paper tape on the bottom of his foot. Follow around his navicular and bring it up to the top of his foot. So you don't want any creases in the tape underneath the foot, because then if he's walking on that, it won't be uncomfortable. And then I'm going to come here, I'm going to anchor this tape down, and then I'm going to push up on his navicular with my thumb. And as I push up on his navicular, I'm going to really try to pull this tape and wrap it around. And I'm just being careful not to get too much in his joint in the front so that it restricts his motion. And then he could stand up and walk a little bit on that and see if you can feel the support.
Oh yeah.
And it should hold up his arch a little bit and help his pain. This is a really nice thing to do for somebody with plantar fasciitis. Where you can massage their foot out, massage their calf, do a few stretches, and then before they leave, just take them up like that. They'll feel really good about it. So you guys can take same position you were in before.
Okay, Mom.
You can do it on
So
the
this
other
one you're
side.
going to use the same
Yeah.
type of tape. This tape is not very strong. I'm just doing it for a demonstration. You're going to use the Luco tape for this. And so for this one, what you're going to do is you have the lateral malleolus here. You only want to cover half of the lateral malleolus. So the bottom half is still sticking out. And then I can push down here. So that will be a posterior glide. And then I can pull the tape around this way.
So you push down on the lateral malleolus.
Yes, I push posteriorly on the
Okay.
lateral malleolus. And I brought the tape around to right here. So it went around like that. So you guys can try it with the Luco tape to really get a good
I
pull
see.
on it. So, but it comes around this way and then back up to here.
Okay.
The increased internal and external rotation range of motion is actually pretty interesting. Because instead of mobilizing the femur, what we can actually do is mobilize the pelvis to move around the femur. And so if I take his hip right here, and if I want to move this hip into internal rotation, I'm going to bring his foot towards me or away from me?
Towards
Towards me.
here.
If I come here, how do I know when I'm at end range? Remember that? Yeah, so
Yeah.
that side comes up. Remember that from measurements. So this is end range for internal rotation. So now I can just hold him here at his end range. I'm not putting any torque or anything on his leg. I'm just holding it in that position. And then I'm putting my hand on his pelvis here. And I'm going to lean into him to take up that slack. And then I can mobilize his pelvis around his femur. So that's an internal rotation. So he should actually feel it on this side. And so if somebody, he's not that tight, but if somebody in the clinic is super tight, they're gonna stop right here. Like that's all, it's common for like, that's all the internal rotation they have. And then their pelvis starts to come up. But he goes all the way down to here. And then come there, and then mobilize it. if I want to do external rotation range of motion, how do I know when he's at end range external rotation? When this hip comes up. Because now I'm mobilizing this hip instead of this hip. But everything I do is exactly in the same position. I'm just grabbing the other leg. And so to improve his external rotation, I can go like this. It's pretty easy to mobilize for hip internal rotation and external rotation. A little bit. So bend both knees for me, Bobby. And say I'm going to take him into external rotation, and this is end range external rotation. Now what I can ask him to do is rotate your knees this way. And then come back. Go 10 times like that. And so now he's controlling it, but he's mobilizing himself into external rotation. Not just holding, you're not doing anything. That's a nice little trick that you can use to get a little bit extra external rotation stretch. Okay, so you guys can practice those in just pulling your leg.
Like literally.
You got me now.
That's the same joke, you could do there. Alright, so long axis traction on the hip joint. You just grab the ankle with both hands right here. I mean, if you get too much on the foot, you can actually cavitate that foot. You feel a little crack in the foot. So if you get a little bit more on the ankle, higher on the ankle, that would prevent that from happening. And then you can just put one foot in front of the other, and then just lean back. And it feels real nice. Get that traction.
Put my
So anybody
shoes
with a
on.
sore hip, somebody with femoral acetabular impingement, or anything like that, sit here back and forth. It's like a pendulum for the hip instead of the shoulder. It's a couple minutes of long axis distraction. Who would you never do this on?
Hip arthroplasty.
Yeah, total hip replacement. Yeah. So you never pull it forward. Yeah. The dog is teaching me a little bit. Having a dream. You guys can go practice that on each other.
Alright. Put on my shoes.
So you gotta be as close to the joint as possible to mobilize it. So I can do it like that, and then like give my hands, like it should be even deeper in there than that picture. So you gotta get your hands really deep in there to do the mobilization.
Okay.
Or I could just tell them I'm gonna use this belt, and I'm gonna put this belt right in your groin to mobilize your hips so that you can bring the thigh over to the forward. So I can bring it there, lock it in place, get it pretty tightened up. And then I could put this belt strap right around my body. And then if I bring them up here with the hip flexion, I can take them in the hip flexion, and then I can mobilize it with the belt. So you could also do a mobilization with movement, where I pull down as I bring it up. This is really good for increasing hip flexion range of motion. It's also good for if somebody has a painful hip when they flex past 90, if they have impingement, or if they have femoral acetabular impingement. This is a nice move to reduce their pain. If somebody has femoral acetabular impingement, what positions are aggravated for them? You guys remember? Hip flexion past 90, or hip flexion in general, and then what else?
Internal
So it's hip
rotation.
flexion. So remember that's the fader test. That's normally positive for them. And they normally get pain with hip flexion and internal rotation. So sometimes you could just assess the patient. Do you have pain with this? Right there. Let me do this move a little bit. Now how's your pain? Oh, it goes away. And then if you're going to educate somebody with femoral acetabular impingement, you don't want them to sit in a low chair like this. Because now my knees go above my hips, so it's too much hip flexion. And then if they're squatting to pick stuff up, you want them to squat in external rotation. That'll normally be pain-free, but if they squat here, that'll normally be pain-free for them. So you guys there's only 2 belts, so you guys are gonna have to switch off with the belt.
Okay.
So go ahead and the radial carpal joint. The distal radius is concave. The proximal row of carpals are convex. You guys can see that. Yeah? So this is the back of the hand. So if I was to extend my wrist, say I lost wrist extension range of motion. With wrist extension, this is the back of my hand, right? So this would be called a posterior roll. So if we have a moving convex rolling posteriorly, which way does the glide have to be?
Rolling convex. Opposite.
Opposite, so it would be an anterior glide. So to increase wrist extension range of
Oh,
motion,
yeah, that's
we're going to
right.
glide the carpals anterior. Now if I was flexing, right? Let's go this way. If I lost wrist flexion, if I want to increase wrist flexion range of motion, we're getting a anterior roll, so we'll do posterior.
Posterior.
So, Bobby, can you just grab that chair and sit down? Facing
Oh, did we start on the one?
So I'm going to do an anterior glide to increase wrist extension range of motion. It looks like an inferior glide, right? Because it's thrown in, we'll push an inferior, but it's actually an anterior glide.
Oh, because
So-
of that anatomical position.
Because it's always in reference to anatomical position. So what I'm going to do is I grab his wrist, I do a slight traction, and then I can just push straight down. That's an anterior glide to increase wrist extension range of motion. If I flip around in the supination, come here, and I can do a posterior glide to increase wrist flexion range of motion. It's a slight traction and then a straight down. Also, to increase wrist extension is if you have the patient put their hand here like this, they can roll their arm forward to try to extend the wrist, and you can do a mobilization like that. Just like that ankle. So it's like a mulligan with movement. Mobilization. You guys can practice this. So when you do this, you'll have the handheld dynamometer. And you'll have them squeeze the handheld dynamometer and see how many pounds of force that they can create. And it'll probably be pretty weak compared to their uninvolved side. And then you can do this technique and their pain-free grip strength will get a lot stronger. So what you're gonna do is you're gonna bring them here. So he's gonna hold this this towel roll. So what I'm gonna have him do, I'm gonna stabilize right here, and with this hand, I'm gonna apply a lateral glide. And when I apply the lateral glide, right after I push, I want you to squeeze the towel. So go here. Squeeze, and then relax. So we're doing 10 repetitions of this. Squeeze, and then relax. Squeeze, and relax. So you do 10 of those, and they'll notice right away when they start squeezing that it's not painful. And then afterwards, they'll squeeze it and pull down the monitor, and they'll have a lot more strength. It's pretty crazy how that works. I don't understand it at all, but it works. And there's a lot of evidence to support it.
So how many sets of 10 do we do?
So I'll do 1 or 2 sets of 10. And then you can teach them how to do it at home,
Okay.
where they stand in the doorway.
Push.
So I can stand in the doorway like this, a block.
And then
I
they
can
push.
in myself. and
Yeah.
squeeze. That's a nice home exercise.
Okay.
So you can practice actually talking.
Slowly. And then the other one is just is it this way? Or is it? Okay, so let's say this is the affected hand. Twist up, twist on the motorcycle, vroom vroom. And then slowly bring back.
So that's for golfers.
Well, for example, this is tennis
Tennis elbow.
Oh yeah, because you're eccentrically
Yeah.
flexion, and then the other one is eccentrically extension,
Yep.
wrist extension. Right, so you're driving your motorcycle, vroom vroom, right? So you're gonna make a sharp left turn, and then you slowly straighten the bike out. By the way, in the clinic, I was trying to explain it.
I'm gonna push your hand down. I want you to slowly drop your wrist down and let me win. So let me win, real slow, real slow, real slow. So do manually resisting. Wrist eccentrics. Another nice, easy way to do it in the clinic. It's gonna be a decanter reflex or a myotome. And then you're gonna take them through the progression of forces. And once you get that green light, you can reassess the decanter reflex and the myotome afterwards. You're going to educate your patient on posture, right? So avoid text neck, avoid, forward head posture at the desk, sit up, shoulder blades back, chin back, all that posture stuff you guys know how to do. You're going to have them do one foam rolling exercise. So it's a foam rolling exercise that they can do. Thoracic extension, or even a pec stretch, assuming that there's not too much nerve tension. And then one postural based strengthening exercise. Can somebody tell me a postural based strengthening exercise that would be good for somebody with neck pain? Scapular retractions, yeah. What else?
Yeah, that was a
Rows.
Rows, yeah.
Pull down. Bilateral external rotation with the band. Bilateral abduction with the band. Prone A's, prone T's.
Oh,
Something. Just a postural based exercise.
YTI.
Something.
That's the one.
So just teach it to them.
Yeah, the YTW.
You can have carpal tunnel syndrome or cubital tunnel syndrome. So cubital tunnel syndrome, you're going to have to do the ulnar nerve glides. Carpal tunnel syndrome, median nerve glides. You're going to do it manually, and then you're going to teach them how to do it on their own for home. It's either going to be a glider or a tensioner. Will be specified on the plan of care. So it'll be one or the other. But you'll have to do it manually, or you'll have to do it, and you'll have to do it. Teach them how to do it on their own. A strengthening exercise appropriate for this patient. So if somebody has carpal tunnel syndrome, the median nerve is irritated. So what muscle group do you think might be weak in their hand? Thumb, right? They'll actually probably have atrophy with their thenar eminence. So you need some sort of hand gripping exercise that can strengthen their thumb.
Putty.
Putty. Yeah,
Or
putty.
or
the
Squeeze a
squeeze
ball,
Squeeze a
something
ball.
like that. So
Yeah.
or the towel.
The
Yeah.
stress balls, the what else?
squeezing a ball can be like the most boring thing in the world. But you can try to make it fun when you're actually in the clinic for them. So some things you could do is like, the drops.
Yeah.
That's like good for the shoulder, but you can actually have them do it for the hand too. And then if Brianna does the drop, where you just
Right.
hold it out, ISO hold, shoulder flexion. So you hold that ball, don't let me pull it out of your hand. Right, so I can do something like that. So now we get a,
Distraction.
we get a stabilization
Oh, so-
exercise for her shoulder. Right, so don't let your hand move, don't let me pull the ball. So now we get proximal stabilization, but we're also working the hand too. And then if it's
Oh, you can use your
if it's
elbow.
a median nerve problem, make sure you squeeze with that thumb. So sometimes they could just get all hands and say, squeeze with that thumb, squeeze with that thumb. You can give them your business card or your credit card or something. It's like, hold
No,
it
not
like
the credit
this.
card.
Don't let me pull it out. And they fight with their thumb to hold the card. So you can just make it a little bit more fun rather than stand there and squeeze the ball 10 times. If it's ulnar nerve, what muscle group do you think is going to be weak? The pinky side of the hand, the finger flexors, the pinky side. So it's the same thing, but you just put the ball here, and so make sure you squeeze with these fingers. Squeeze with those fingers. Don't let me pull it out. Putty with those fingers. Anything. But focus on that side of the hand. And then a postural-based strengthening exercise. Same thing as for this.
Just
You can have your postural-based strengthening exercise ready. And you can use it for both
When you're
cases.
on the table typing, make sure you
You will have a total
straighten.
knee
Yeah, that's
arthroplasty.
postural.
That will be one of the cases. Total knee replacement, probably 2 weeks or something after surgery. You're going to have to do manual therapy to increase knee flexion or knee extension range of motion, whatever the patient's deficit is. So if I wanted to do manual therapy to increase knee flexion, you can do a mobilization to increase their flexion. You can do a mobilization with movement. You can do a posterior tibial glide, depending on where their range is. Remember that one off the edge of the table? You could just do a knee flexion stretch. You can have them prone and just do a prone knee flexion stretch to try and increase the range of motion. Increase extension, you could do a knee extension stretch, or you could do a posterior femoral glide. That one that we talked about when they're lying supine and you just push their knee straight. Doesn't even have to be a move, just lie on supine and push their knee straight. So it'll be a manual therapy to increase range of motion into knee flexion, or I put and, but it's going to be one or the other. And then you're going to teach them a home stretch. either to increase their knee flexion or to increase their knee extension. So something that you do on the manual in the clinic, and then teach them how to do something on their own. And then one functional strengthening exercise. What's a functional strengthening exercise at a knee replacement? A squat,
Squats,
a sit to
yeah.
stand, a step
Mini
up,
squats.
a lunge, something like that. For don't be super safe and boring, just do like sit to stand. I want to see you guys give me a little bit more. So if it's like a right total knee replacement, you can put the right foot back and the left foot forward and have them stand up like that to try and get a little more weight on their right leg. Because how that person in reality is going to stand up, they're going to go like this. And they're only going to use this leg. So like, make sure they put weight on that leg. It's okay, they can weight bear on it. There's no restrictions with a total knee replacement. So make them use that side. You can give them manual contact. So if I'm telling Noel to sit to stand. So go for a sit to stand now. Okay, if this is his involved leg, let's try and just flip him around. So bring this foot back. So bring this foot forward.
Okay.
This foot back. And I can say, push your leg into my hand. Go stand up. Now stand up. Push your leg into my hand. Stand up. So as he does that, it forces him to put more weight onto his leg by doing that manual contact. Or you could put even like a dynamic surface underneath on the other leg. And just be more into besides like 10 sit to stands. And like pay attention to the form, give them some feedback. I want to see a little bit more from you guys in this 10 sit to stands. 10 step ups. Like if you're doing step ups, make sure the pelvis does not drop in. Make sure they're eccentrically controlling themselves to the ground and not just letting themselves drop down and drop back up. Where's that small step? So if I'm doing a step up, right? I could literally just go like this, right? And I'm barely using my leg because I'm plantar flexing my foot and I'm letting my pelvis drop down. And so I could have my pelvis level and I could keep my foot flat. And now I really have to use this leg, but or else I can go like this, and I'm not doing anything. And so you could cue them to make sure that they're keeping good form, and make sure that their knees
Maintaining
not
the level.
collapsing in, anything like that. So you're on a level pelvis.
Yeah.
Right, so if you have headlights here, right, the ASAS on both sides, those are your headlights. Make sure your headlights stay sticking forward as you step down. Right, don't let one headlight drop below the other. Okay, you're also going to have an ACL patient on the exam. It will be a hamstring autograft or a patellar tendon autograft. When can a hamstring tendon autograft start running?
12. I think it was it
Yeah.
12 weeks?
When can a patellar tendon autograft start running? Running, jogging.
I don't remember.
Yeah, hamstring is a weakness, it's a little bit longer.
Immediately.
No.
So a patellar tendon autograft. So you guys are going to see ACLs guaranteed.
Was it?
The first thing they're
8
going
to
to ask you
12?
is when can I jog?
Yeah.
You need to be able to answer this. Everybody got this wrong on the exam except for one person. So you guys need to be able to answer this question. A patellar tendon autograft is normally cleared to run at 12 weeks. Or
Oh,
3
that's what I
months.
was thinking.
But they
12,
have to
yeah.
have clearance from their doctor
12.
first. So you can tell them normally around 3 months,
Yeah.
but you have to have your doctor's clearance. A hamstring tendon graft is cleared to start jogging at 4 months, so 16 weeks. But they have to have doctor's clearance first.
I got it right the first time.
The hamstring tendon takes a little bit longer to heal because it's tendon to bone healing, where the patellar tendon autograft will heal a little bit faster early on because it's bone to bone healing. But if you have,
I'll just ask you about that.
yeah, if you don't know, if you don't know, don't make up crap to say when your doctor says so. You're gonna have to do a manual therapy exercise to increase knee flexion or extension, a home stretch for knee flexion or extension, and then an exercise appropriate to address a specific deficit dependent on their stage of rehab. So there might be one person in the first stage of rehab, there might be one person in phase 2, and there might be one person in phase 3. And so it'll tell you the exercises that they've been doing, and what they're allowed to do and what they're not allowed to do. You'll have a rehab protocol. In general, one of the most important muscle groups to address with an ACL?
Quads.
quads. What else? So you have knee extensors.
Yeah. Yeah, I said knee extensors.
Knee
Yeah.
extensors.
Yeah.
Okay. What else?
Oh, your hamstrings.
So so you don't always have to think about the knee. Sometimes you could go more proximal. Hip abductors. So any sort of hip abduction. Remember, weak hip abductors is going to make somebody fall into the position.
Oh, yeah.
And that's going to make them prone for another ACL injury. So strengthening the hip abductors is huge, really for most knee patients, but really, really important for an ACL patient. So you might have to do a hip abduction strengthening exercise, or a quad strengthening exercise, or a hip extensor exercise. So glute max, glute med, glute min, and quads are all critical for the ACL patient. Those are the muscle groups you want to focus on. And remember, I gave you guys a whole lecture about a hip abduction strengthening progression, and like what are good hip abduction exercises.
That video.
So that might be a nice thing to go back and review. I think it was.
Yeah, that was the guy. Yeah.
Even like sidestepping.
And then there
with
was
a
the
band,
list. Yeah.
That's a great exercise, sidestepping with a band. But you want their hip a little flexed and their knees a little bit flexed. If they're cleared for that, that's the exercise you should do. You're gonna single leg bridge, a side plank with the side that you want to work down. All of those things are good for hip abduction strength. Sideline hip abduction if it's early on in rehab. Yeah, so the kicker off the step. It's an awesome exercise. Okay, you'll have Achilles tendonitis. You'll have to do a joint mobilization to increase range of motion into dorsiflexion. Eccentric plantar flexion strengthening, a balance exercise, and a home stretch to increase dorsiflexion. So a calf stretch. That's what you'll have to teach them. You'll have an elbow tendonitis, either a golfer's elbow or a tennis elbow. You'll do a mobilization to decrease pain. What mobilization is that? Lateral glide. And a stretch appropriate for the patient. So if I have lateral epicondylitis, what stretch? If I want to stretch the wrist extensors. Yeah, right there with a closed fist. And then if I have golfer's elbow, what stretch? Right here with the fingers up.
Extend it.
An eccentric exercise, you can do manual eccentrics, you can do flex bar, you can do it with the weight. An eccentric exercise. One additional strengthening exercise. What's an additional exercise that you can do for them? Remember, this person is a tennis player, right? And they have pain in their elbow. What's something else that you can address? You don't always have to think about this site. You can think proximally, right? Normally these people have some sort of shoulder girdle weakness.
Yeah.
So you can do some sort of shoulder girdle,
Shoulder,
external
yeah.
rotation strengthening,
Like-
postural strengthening,
Yeah.
think proximal. Normally these problems happen because of proximal weakness. And they start relying on distally too much because they don't have the strength proximal. And so you can't fire a cannon from a canoe. You
Yeah.
gotta have a strong base before you can have that strength distally. And then patient education. What's some education you can give for somebody with elbow tendonitis?
Groceries, pick it up this way versus this way.
Yeah,
Yeah.
if it's tennis elbow, if it's golfer's elbow,
Yeah.
if it's golfer's elbow, they want to lift this
Pick it
way.
up this way instead of that.
And then you could also recommend the strap for them,
Oh, yeah,
especially when they're
yeah.
playing tennis. The last one is FAI, femoral
Femoral
acetabular.
acetabular impingement.
One manual stretch to address symptoms. If they have femoral acetabular impingement, they have pain with hip flexion. So hip flexion is this.
Yeah.
But also, what else can put you, if I'm standing here, what else can put me into hip flexion? My pelvis, right?
Yeah.
So is it an anterior tilt or a posterior tilt?
Posterior
And-
tilt.
Anterior.
Exactly. An anterior
Yeah.
tilt will increase hip flexion. Let me get the pelvis.
Here you go.
No, I need a femur. There's femur.
Oh.
And so if you look at this femoral, no, it's-
Yeah.
it's all twisted. Okay, so if I flex my hip, right, that can be painful for FAI. So that's a anterior tilt will actually put me in the same position as hip flexion. And so an anterior tilt will be an irritating position for somebody with FAI. So what's a stretch that I can do to reduce an anterior tilt? The Thomas stretch.
Yeah, Thomas stretch.
And so you could do a Thomas stretch, you could do, depending on what's tight, you could do rectus femoris, you could do iliopsoas, you could just do both. If you're not sure, just do both. And so you know you're gonna
Iliopsoas stretch.
And so you want to encourage, this is one of the few patients that you want to encourage a posterior tilt with. So you do the Thomas stretch, but then you want to do one home stretch to address symptoms. So you could do like a kneel and hip flexor stretch, all right, which would be great for these patients. 2 therapeutic exercises that will benefit this patient. Remember, you want to encourage a posterior tilt. So maybe a posterior pelvic tilt in exercise might be really good for this patient. To open up that hip joint so it's less pinchy. Also, this is one of the few patients where a rectus abdominis strengthening exercise, a crunch, might be good for them. Because if they have a strong rectus, that'll pull their pelvis into more of a posterior tilt. What else could benefit this patient? Hip impingement. Also strengthen the hip abductors so they have better control of their pelvis. And so really it's like one posterior pelvic tilt exercise, one hip abduction strengthening exercise. Will be good for them. And then patient education on positions to avoid. And when you're squatting to pick stuff up, you want external rotation. Those are all the cases for the competency exam. So you gotta brush up on those things. Make sure you review your upper extremity dermatomes. Make sure you review your appropriate TheraX exercises for these conditions. And you guys will be good. So it'll be like just like the midterm where it says perform this, 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 and this. So it's gonna be a clinic here. It's gonna tell you what to do. It's not gonna say, perform a single leg bridge, but it's gonna say perform an appropriate hip abduction strengthening exercise.
Okay.
Sound good?
Yours is harder than Leo's.
Yeah.
Or
Well-
just more.